This is the lingual cortical engagement. The stability was very good, right? No, to turn you can go.
So, you just caution our pronounce on area, like when you talk with the fracture of what abutment neck,
abutment neck. Okay, this is the premolar area, no? Second premolar. Below the tread lucency is there. This is the basal area. This is the basal implant. You can see lingually the bone is very good, but buccally. So if you place compressive implant, this 4 to 5 mm will be exposed without any bone. So you need to do bone graft and all, but this simply solves the problem. What we need is stability, right? See, if you see here, I am feeling resistance because I am touching here with the lingual, right? Lingual. Here also I am feeling resistance because this is touching here. If I am drilling like this, I could have gone deeper, right? If I am not respecting this resistance, I would have perforated. No, like this.
Over the
lingual cortical.
Yeah, towards the, here we have the intermittent space is more right towards the right of the patient. The bone area.
Yes, they here. Here the inter-implant distance is more. That is not an issue.
Because we are replacing only to see.
No, we have placed 7 implants now. That is enough. Even the inter-implant distance is more. This implant stability is good.
Sir, I have one more doubt.
Can you proceed?
Sir,
so, you know, here the implant is little bit close to the, no, but not a problem. No, it's not nerve, sorry. This is the nerve, right? This is the nerve. This is the nerve, right? Slowly it is coming. So then the implant is very far. This is the bone marrow space. This is not nerve.
Okay. So here, to reduce that inter-occlusal distance, okay?
Yes.
So can we just little easily bending kutla either and the action is
see one more thing what we can
behind that.
Yes.
So rather than leaving it like this, can we just give a easier tilt of this?
Yes.
So that in the occlusal
yes, without affecting the parallelism of all the implants you can do. Because if you do but yeah, there won't be any problem because you have got good number of implant on the other side. When the patient is biting on this side, the force is going to get to all the implants. If you are very much doubtful, what you can do is you can do a double welding.
Okay, anyway,
that will increase the rigidity.
Okay. So when
you put one wire, you put one more wire over there.
So much of
it will increase the rigidity of the system. What I was thinking is, see, this is the mental foramen, right? Here. So behind this there is good bone. Behind this implant, we can place one more implant actually. No, this is the mental foramen. Here it is safe.
But the room very close sir.
Yes, that is one. So we can place a one implant, calculate. BCs we have to place because lingually it is higher. So this is the mental foramen, right? Okay, we will place one small BC. Alright, no? Okay.
Sorry, sir.
Okay. It looks somewhat good, right? So first immediately see the sinus, how much it has gone, front, down, back. Break the image into 3 circles. Yes. Of course, here matching tooth are present because of the panoramic section it has got. Comparatively, the second premolar it is good. Okay. So you can like, yeah, even in the first molar actually it is good. So yes, so we don't have to go till 8. That is big relief. Okay. So that is a separate topic. How to avoid pterygoid? Because the moment you put implant in pterygoid, the angulation of the abutment is erratic. You have to bend. If the stability is not good while bending it may. So you have to go to multi-unit. So as much as possible we try to avoid pterygoid and finish. But sometimes pterygoid is must. Some pterygoids are helpful to avoid zygoma. Okay, right? In some cases what we did, there is no bone in the 4 or 5. The last case, there is no bone in 5. From 4 only our implant starts. Ideally needed zygoma. But we avoided zygoma by using pterygoid, by using multi-unit and titanium frame. Okay. See,
Zygoma.
Intraorally, complete.
Where is the zygoma asking?
How will you avoid zygoma in the sense? I don't know. Like,
Avoid zygoma. There are some indications for zygoma.
Oh.
Right, when there is severe bone loss situations.
Very appropriate.
We started we started sometime now zygomatic implants before doing this multi-unit control. So we did around 160 zygomatic implants. After we started using this multi-unit, this titanium frame, we have not done single zygoma in the past 4 or 6 months.
And multi-unit 4 implants.
No, 4 or 6, not 4. I told no, all on 4 we don't have any experience. Pterygoid, anti-leaf 4 implants.
Same how we did with our normal.
Yes, like how we did last case. Because zygoma is quite successful, but when it comes to complications, there are some complications, very difficult complications. So divide into 3 circles. First circle is good from this view. We don't know the buccolingual view. The second circle here it is good. Okay, so we don't have to go to third circle. Here also it looks somewhat maybe palatal socket of 6 and 7 we can place. Otherwise we have to go to
This is the hard palate.
yeah, maybe. Yeah. So we will see the right molars first. Both sides, second circle we will first see. We will start from the mesiobuccal root of 6. Okay. As I already told, the mesiobuccal root of 6, just palatal to the mesiobuccal root, you have got some good bone here. Of course, it's not very ideal, but some bone present. Keep this in mind. So, if you place a short implant, we can place 4 into 10 or 3.75 to 10. The previous case or some case, I don't know which case, we tilted and we went like this. And we didn't see the CVCT, right? How it came, you have to see it. Okay. If there is some good bone here, we can do that, but here we cannot do that. So now we are slowly going towards the palatal socket. Palatal socket is one of the area where if you use properly you can avoid pterygoid. Palatal socket. That is how we avoid pterygoid for many cases. See the palatal socket. See, because of this bone infection, it has gone into the sinus and it is a chronic irritation. The sinus floor has thickened. So if you place here, it is unpredictable implant. You may get stability or this may break, and you may lose stability. Or we can try here, the 6 palatal socket. If the patient has come before 6 months or 10 months, there would be some good bone here. We could have placed a 7 area, 7 mesiobuccal area. Surprisingly, there is some good bone is there compared to here. You can place. You can start from here and aim for it. Short implant like this. Maybe 3.75 to long 0.5 also we can place. Now we are going to see the palatal root of.
This is 6 only, right, sir?
No, this is 7.
Okay.
Mesial
So mesial root of 7, mesiobuccal. Now we are seeing the palatal socket of 7.
So,
Yeah, this is good, right? This is excellent. More than 6, this root looks promising.
But still here we have
Some bone loss is there.
This is also quite thin, right?
Yes, but this is no problem. But here we got some good
So
bone.
when we are going through the socket, we have to be careful with this retention of this bone,
Yes,
right?
yes. So there are 2 options. One, you can place a 5.5 basal. It will get support from here and here. And one more option is you can place a put till here, beyond the apex till here, wherever you are feeling the drop. Not necessarily nasal floor, sinus floor, because if you go through the apex, you will go here only. Go from here to here, what is the length available, feel the drop, and you can select a BCS basal design 3.3. Okay, or even a compressive. If you do a minimal alveoloplasty here, some good bone is there. Even if some 2 or 3 threads are exposed, if you okay with that, we can place a 4.2 millimeter implant. So the 4.2 will get stability from here, and you may go till here. Or if we want to do some heroism, we can go till this way. Right? Go to tilt the handpiece, like how we did. No, in one case we tilted the handpiece different direction. Go till here, and you measure it, and you can place a compressive implant. This is also one option. But tilting the handpiece in the 7, retracting the cheek and all may be difficult. But it's worth trying. Or straight away you can place a compressive implant like this. 4.2 to 13 also will work good. It will get good stability, nice. So after seeing 7, I feel there is no need for pterygoid attachment. You can place one socket, 7, one implant, 6 also,
6.
one implant. The advantage is the abutment will be in decent position. If you put pterygoid, it will be projecting. Prosthetic steps will be difficult. So what we are planning is we can plan 2 implants. Okay. Now we will see the palatal socket of the 8 also. This is 7. The 8 looks more promising actually. Okay. The 8 also you can place a compressive. Here lot of good bone, undisturbed bone. You can place a 4.2, 13 something like that. Okay. This is the greater palatine canal coming here. It opens in the between 7 and 8, right? We will see where it opens. See here, no? It is where it opens as the foramen, the greater palatine foramen area, between 7 and 8. If you see this picture, this is the 8. If you just tilt slightly distally, it is pterygoid. Luckily the sinus has not gone till here and all, it doesn't. The sinus, imagine if the sinus is going like this, then placing pterygoid is difficult in this situation. But here, you just tilt here, it will go. It's an easy pterygoid case. You will just tilt pterygoid like this. Okay. So anyhow, we are not going to. So all the palatal socket of 6, 7, 8, they are good. So anywhere we can use. The only thing, the bleeding, lot of dilation of tissue. So right side, we are now coming to the 1-1 area. Excellent bone. Okay, this is the 1-1 cross section. Observe the outline, labial plate thin. Palatally there is good bone. You can keep the finger here and go palatally, long implant. Anyhow, you are going to do alveoloplasty now till here. Okay. Or after doing alveoloplasty here, you can place implant like this or like this, whatever it is. Okay, that is your wish. If you place implant in this angulation, you have to bend it like it. Okay. If you place implant in this direction, you don't have to do much bending. For planning, putting implant here, you have to plan alveoloplasty first, right? So imagine till what level you will be doing. Welding you want to see or?
Double welding.
So
No, single welding. Welding
same
or-
like yesterday.
Yes. Yes, okay. Now start, Maran. So how much alveoloplasty we do based on the lip movement, gummy smile or what? So definitely for 4 or 5 mm we will be doing alveoloplasty for this patient. So maybe till here. Okay. After that we can place implant like this. But the nasal floor is good, excellent bone. Okay. So we will be placing one more implant. You see the maximum length we can get around 18 or 20. Now the key area is the 1-1. The next key area is the second premolar, right? The second premolar area is not good. Most probably the premolar would have been like this, right? Lot of bone loss, it might have been extracted or fallen off. So before that, it removed all the bone till the sinus floor. No, the bone level has gone. Palatal bone is thick. That is why. That's what X-ray gives you the history of the patient for past 10 years, 20 years. You can tell wherever we went, what is their diet, long back, what kind of dentist they visited, how they take care of the teeth. Everything we can see from CAOPG. So axially 5 is not ideal, right? Axial placement. But if you tilt slightly, so this is axial. If you tilt slightly, easily, similar to all on 4, you get good bone. Okay. So this will be a good plan. So around 4 into 16 implant. Okay. So we know about tilting from 5. But there are 2 styles for tilting. Okay. This is mesial tilting. But there is one more tilting happens on the other dimension. Yes. So this tilting, you are tilting palatally here.